Good to see you all here. About to enter end-to-end review, and the team is actively involved in end-to-end review type questions. So we have a lot of content today, and we look forward to talking through it all with you. Joshua, hello. Good to see you. It's good to have you here. We'll start at about 3 minutes after the top of the hour.
By the by, with this last minute, I just want you to know I did kind of share information about more involved participation with folks connected to the National Center for Farmworker Health, and I just waiting to hear back from them.
Fantastic. We can't wait. I last saw Joshua.
Joshua, what does it say on your something about a champion is tiny letters? What does the whole thing say?
Josh, you can just say where you're from too, because I think that explains what you just said to me.
Okay, understand. Okay, yeah, this is related to the Agricultural Worker Access Campaign. The National Center for Farm Worker Health works to to increase access to healthcare, both medical services and health related needs for agricultural workers and their families in around the U.S.
Thank you. That's splendid. Really a different perspective for us. Thank you.
Yeah, Joshua has a history of being involved in other domains. He was very much involved in our health literacy and language access domains, and he's an ally, and I'm glad to have him back. All right, I think we're ready. We have so much content. So I'm going to get started. Again, my name is Sarah DeSilby. For those who don't know me, we are entering a really critical time for our domains, which is known as end-to-end review, which is kind of the process where things get settled and refined over the course of time over the next month and a bit ahead of the consensus vote. Again, lots to cover. So next slide. Thanks for joining. Folks are muted upon entry. Calls are always recorded. Please send all chats to everybody. And then just know personally, it's hard to facilitate and receive personal chats. And if you send them to me, I'm bound to read it out loud. So if you have thoughts, it's best to send them via email, because otherwise I'm going to read them out loud, and maybe that's not what's on it. Just send them to everybody. We do try to facilitate a robust conversation as we go forward. Next slide. We do follow federal and standards-based antitrust practices. All Gravity Project participants, including participants in the community call, have the responsibility to comply fully with federal and state antitrust laws. Individuals speaking or writing or providing any form of communication, including in this call, have to refrain from any antitrust violations. This includes direct violations and anything that might be construed as it's just construed as a violation. Thanks so much. It's just part of doing the work as a standard. Next slide. We're going to go brief highlights and overview and announcements, and then a lot of content, and trying just to ensure that we can get through the content, knowing that the content from now until the vote is fairly consistent. We're hoping to time box. We'll talk more about that going forward, but entering our end-to-end review on all of our domains today. Next slide. All right, next slide. Again, these are alternating terminology calls. Enhancements alternates with new domains. We are in the new domains call. Next week is enhancements. Our technical work stream meets every other week from 1 to 2. We just met talking about the STU 3.0 roadmap. That recording is available on the Confluence if you missed it. It was led by my colleague, Corey Smith, the technical director. Next meeting on the 30th is dealing with one of the items on that roadmap, exploring program eligibility and social care enrollment use cases. That's on the 30th. And then our next implementation affinity meeting is discussions and return on investment, closed loop referral standards, and patient and provider burden. So that's on the 29th of May. Next slide. Any questions on the roadmap or announcements? I mean, the announcements? No? Okay, next slide. Gravity Project vision is the Gravity Project strives to create a world where health and social care organizations readily share the information needed to effectively meet the social needs of individuals, advance health equity, and improve health outcomes in communities by using standard terminology and technology. As mentioned, this is actively undergoing review by our steering committee with some word changes that should be finalized at the end of the month. Next slide. I'm not going to go over the lexicon again. There's a lot to cover today, but I present it for viewing. Next slide. Incredibly grateful to our members. We couldn't do it without all of our members either offering direct financial support, knowledge support, or representation for critical populations. Again, very, very grateful. Again, we're the only accelerator that has that designated membership to make sure that critical voices and community-based organizations and patients are represented in our governance. Next slide. This is our roadmap. It's been confirmed for a bit. You can see we're in our spring domains with the enhancements pairing, and then in the fall we head into those neighborhood level domains of food access, neighborhood safety, and access to green space. We are currently in the middle here. We are in April and just kicking off our STU 3.0 update, as I mentioned, that started yesterday. And then working on the affinity group as well. So all these things happening in tandem, busy, busy times at Gravity. Next slide. I just want to mention everything we do. This is a member-led organization. We have 2 different governance bodies, a strategic steering committee and operating committee. Everything we do is voted on by consensus. Our deliverables and our terminology meetings are voted on by consensus. What is prioritized, the domains we pick is all picked by members. So it's truly a collective of the voted upon priorities of the whole body and never just one entity. Next slide. And we are consistently and very carefully representing our principles in all we do. We created them in 2019. They guide all of our build and all of our standards development. They are improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and preventing, reducing, and remediating harm. Next slide. What we're doing here in the terminology call is identifying all standardized instruments that are used to identify a domain, identifying the core diagnoses or findings or conditions that need to be named, identifying the goals related to that risk or condition, and identifying all the things we do, the care team and the person, to address that risk or promote that protective factor, which is a new thing for us here at Gravity. Next slide. Where we are, we're just kicking off, as I mentioned, and review. There is a lot of content. We're going to talk about time boxing the whole time. Again, everything you see here is available on the master list that will be published at the end of the week. And so if we are not able to address all questions, we will come back next week and keep on going through questions. We have a formal process for end-to-end review as well. We'll describe that in a second, all heading toward that vote in May, on May 29th. Next slide. We have realized that time is precious and we're having to slightly modify our approach as we do 3 domains at once. So as noted in the past, any instrument that's been presented in a prior meeting will not be presented again. We're not going to present the general interventions that always apply to every domain. We're not going to present directly any existing intervention concepts the SMEs have determined apply to this domain. These are interventions that we all defined in consensus in prior work. What we're really trying to focus on in our calls are newly identified concepts, definitions, and terms for community review towards consensus. Everything is always available on the master list on the Confluence for community review, right? So we're really trying to highlight and focus on things we have not seen before. Really, again, just to streamline things, because even with this approach, we have 60 slides to get through. So much content, so much SME work, so much work from the amazing terminology team, Sarah Bahal, Asha Emanuel, thank you so much. Monique Van Berkem, Susan. So there's a lot of work going on. We just want to make sure that we get through it. So this is a slightly refined approach, really focusing on new things. Next slide. End-to-end review. For those of you who have not been part of a Gravity terminology curation process, we have a very formal process, even if we really work in consensus collaboratively in kind of informal ways. End-to-end review is a time where we step back and start thinking about the whole master list, and we ask very clear questions about it. Are there missing concepts across any of those 4 activities, across instruments, across diagnoses, across goals, and across interventions? Are there incorrect concepts that need to be changed? And this is a lot of what the terminology team dives into, is just phrasing things well, or phrasing things in ways that fit into the structures of the terminologies of reference, like ICD-10 or SNOMED CT. And then, so that's what we're doing actively. Are there things that are unnecessary and need to be removed? So things adding, things refined, and things removed. Once we enter end-to-end review, comments and edits are formal. They are offered in written form with a rationale and evidence for suggested alternate approaches. And this is because we've already done a lot of work since February 6th, and we need to have some kind of change control for disruption for what you've already come to as a collective. So we have formal approaches. So every edit or comment to the master list is sent via an email to gravityproject@hl7.org. This includes like things missing, please add this as a program. And then incorrect things and also unnecessary things. Know that to do this well, given the fact the slides are slim and focusing only on new things, you have to review the master list entirely, because the only place where everything is there. But hopefully we make that easy by posting it posting it at the end of the day on Friday. I think that's what my amazing friend Sarah Bahal is doing. Yes, fantastic. Thank you. And then once you submit the formal comment, we send it up to our subject matter experts and go from there. All right. Does this make sense? Any questions on end-to-end review? The method is consistent across all of our work, but it's a little bit more formal than what we've been doing before. Okay, next slide. We are rounding, and we try to, the team and I, we were talking about like how we present things. We like to present new things at least twice. And so we're going to revisit the elements of trauma-informed principles that we revisited 2 weeks ago today. Next slide. So whether it be the domains we're addressing or the current times, we're consistently talking about trauma-informed care and trauma-informed principles within our work. We wanted to take a moment to clearly highlight these principles today. Next slide. And this is just base common practice. Really hugely grateful for the Center for Healthcare Strategies, which creates the trauma-informed care toolkit aligned with the principles of SAMHSA. So trauma-informed care seeks to realize the widespread impact of trauma and understand paths for recovery, recognize signs and symptoms of trauma in patients, families, and staff, or ourselves, or our community members, subject matter experts, integrate knowledge about trauma into policies, procedures, and practices, and actively avoid re-traumatization. There are these, just like we have our data principles, there are 6 core principles of trauma-informed care: establishing safety, making decisions with trustworthiness and transparency, peer support, collaboration, empowerment, and humility and responsiveness. You'll see themes of trauma-informed principles throughout our domains as well, from the terminology we're creating. in toxic stress and our discrimination and racism domain. But just want to note that these principles are really fundamental to how we operate as a community and how Gravity as a team is operating internally all the time, and especially now. Next slide. All right, so this is my time management slide. Next slide. So much to do. We are beginning end-to-end review. We have time to refine. Again, everything should be, the pace of new things should steady and slow over the course of the next weeks. So we're trying to just present the content at least and try to time box each domain with about 20 minutes. And then next week we'll come back. So we want to just present all these new things if it's possible. We did a similar thing a couple meetings ago. And then come back and iterate and refine over the next weeks. And some of the things in this set are very like exploratory, like a first time of figuring out a phrasing. And so there's definitely a lot of work to do there. And we love your comments. Please send us an email about how to refine them. But we really want to try to present all the amazing work the subject matter experts have been doing today. And so we're going to try to time box about 20 minutes for each domain, and we'll see how we do. Next slide. Okay, any further questions before we get into the work? All right, okay, so protective factors end-to-end review. This is the first time you're seeing a lot of this content because of the nature of our work. We had protective factors combined with our toxic stress domain because they're very interdependent and they can be mirror images of each other. And then we realized we really needed to create special SME, subject matter expert space, to totally think just from a strengths-based perspective. So we created a whole new subject matter expert cohort and are working with them, empowering strengths-based language. So there's a lot of new content coming to you, and there's going to be, in most of our domains, this one's going to have the most probably change over the course of the next weeks because of that decision. Next slide. The whole point of protective factors is really, we've been planning for protective factors approaches for a very, very long time. It makes me think of my dear friend, Elena Kalinowski, one of our members and a dear colleague who's a social worker, right? So within protective factors, our principal task is naming the practice of working from strengths-based approaches rather than deficit-based approaches. Strengths-based approaches are core to the praxis of pediatrics and family practice, nursing, and social work. And I should have added peer support there, right? I didn't. I'll fix it. In all of these, we work to name the strengths and assets we assess and foster to promote well-being, thriving, holistic understanding of people in community and family, and promote capacity. So, and we noted this, my friend Corey and I talk about this all the time. The current deficit-based and deficit-focused medical model, this is very problem-focused. And so we have to explore as a community where these concepts will live in records. We have a problem list and we don't have a strengths list, but we have both, right? So again, we've been doing, all of this information is documented in care plans and eco maps and social work assessments and community health worker notes. All of this is the work that we do on a regular basis. It just doesn't have a normative place within the schema of data and data classes. And so that's just something that we think about as we do this work. Next slide. All right, so the instruments have not changed, but they likely will change very soon. Again, we have a whole new crop of subject matter experts we're roping in, and very grateful for our colleagues, the American Academy of Pediatrics, who we're going to be meeting with on their strengths-based approaches over the course of the next few weeks. Again, augmenting and supporting our current SMEs in just making sure we have a robust set. Next slide. Currently, we have the PCE and the BCE scale. We presented those some time ago. Again, there should be at least a few more instruments shortly. Next slide. Again, everything is available on the Confluence. Our approach to protective factors requires that we actually consider a new element on our intervention. Hi, Mark. Yes?
Hi. You may be covering this, but I just wanted to check. The instruments on this website now are the ones you mentioned around childhood protective factors, and I just wondered, will we be seeing discussion of adult protective factors? I'm just thinking
Absolutely.
about how there may be shifts from poor situation as childhood to better as an adult
Mhm.
or vice versa. So
Yes,
just checking for
yeah.
the roadmap.
Yeah, and I just want to note that there actually are not a very, like, our instruments may not, may be inadequate to represent this domain. But we don't always have a direct correlate between instruments and concepts, and you're going to see that very, very shortly. But good to highlight, Mark, and thank you. The terminology team is actively doing a whole lot of searching and scoping for models on strengths-based assessments. But for right, yeah, that's a good thing to call out. But again, our concepts are fairly liberated from that perspective, even if our instruments are bound to it at this time.
Thank you. So I'll just throw out the idea that you may already be thinking of it. If we can't cover that intersection, it seems important enough to flag that we acknowledge its existence, but we may more work may need to be done in some way or another. If
Yes.
if that's the subject matter expert's conclusion.
Yes, we do that often. Like we did a similar thing with incarceration. There was no great instrument for that domain, right? So we didn't, so we recognized a gap. It doesn't mean we have a concept gap though. So I'm just going to highlight. So we will have concepts able to represent adult findings, even if we don't have a great instrument, if that makes sense. More to come, I promise. And we do call that out. But yes, and we are actively looking. And the cool thing about adult strengths-based assessment is it's usually much more collaborative and visual. There's graphics and there's a blooming methodology which uses a visual of a flower. It doesn't actually tie very elegantly into like a binary question answer model. They're gorgeous. But yeah, so we're definitely trying, Mark, but our concepts are actually applying, they're definitely able to represent adult concepts, and we'll see that very shortly. All right, maybe we can show the blooming flower next time, which is very pretty. Okay, so in our first year's gravity work to define the types of interventions critical for centering patients, addressing social risks, and that's the intervention framework. One of the things that we realize when we're talking about protective factors, if we're moving from deficit-based approaches to strengths-based approaches, we have to move to strengths-based approaches in our interventions as well. We're not trying to minimize protective factors, we're trying to promote them, foster them, strengthen them, right? So we had to lean into the literature of social work and nursing to find promotion. It's already an existing SNOMED concept, a SNOMED like procedure. And so we have to add that to our lexicon of intervention framework in consensus, because you find a strength and you grow it, right? So just basically in summary, moving from deficit-based approaches to strengths-based approaches means we have to add an intervention type. So we're suggesting promotion, which is defined as an activity that supports or encourages a cause or goal. And you'll see that be tied to our intervention concepts over the course of the next slides. It's already actively suggested in some updates in toxic stress very shortly. Next slide. Lots of talking. Next, and I put findings here because problems like strengths are not necessarily diagnoses the same way. It's just tricky. There's a lot of breaking and radical thinking when you start thinking about strengths-based perspectives. It doesn't fit. Next slide. All right, so in order to create the concepts within the protective factors and strengths-based domain, the terminology team, the subject matter experts literally took I think it was 8 different frameworks of strengths-based assessments and protective factors and are marrying them. This is an ongoing process into a general framework of how to build strengths-based language. They include the models presented a couple weeks ago, representing and centering American Indian and Alaska Native concepts. The framework's in progress, but it's presented here. And these, again, are not age dependent. It's structural supports, social connection, balanced nutrition, physical activity, which is kind of in refinement, creativity, connection to nature, mindfulness and spiritual connection, social emotional competence, and specialty called out parenting and caregiver competencies because they're so interconnected to the thriving of the child. And all of the terminology you're going to see over the course of the next slides tie in here. Hi, Lucy.
Hi, Sarah. I don't know whether this is documented, or whether it really fits here, but I have to bring up advocacy for policy change, since policy has created such an imbalance with respect to protective factors.
Yeah,
So
yeah.
does advocacy for policy change fit here? It's not patient-centered, or it doesn't have to be, or maybe it even shouldn't be. So that's why I'm sort of struggling with how to phrase where to put that. Because if we want long-term structural change, we need to do policy advocacy. I mean, we all personally probably do that somewhere, somehow, but does it belong in our framework?
So one of the things we presented when we kicked off our work in protective factors was the work that the Office of Disease Promotion and Health Prevention did in 2023, I think, in partnership with the Ripple Foundation, publishing a paper called, I'm going to look at it, The Equitable Long-Term Recovery and Resilience Plan for Social, Behavioral, and Community Health. And those are those vital conditions. So we always think about policy, and I'm putting that amazing paper in the chat that, like, sadly, it's hard to find now, but I think we try to consistently think about policy in all of our domains. We reference the WHO Conceptual Framework for Action on the Social Terms of Health. But part of what the Vital Conditions Framework does is talk about how all of these are connected to community vital conditions and community strengths as well, which are fundamentally driven by policy. So yes and yes and yes. And that kickoff has the links to all of those, and it's certainly all of the Administration of Children and Families protective factors framework that they developed drives strengths-based assessment into everything happening at ACF, right? So it's 100% policy is a part of intervention, and we do try to highlight with that when we can. And the DSG Protective Factors Framework for the Administration of Children and Families is on the Confluence. And I think that the Ripple Foundation paper should be there as well, but Lucy just echoing and supporting. Yes, yes. Whew. Next slide. I hope that answered your question. All right. So protective factors, again, I think we're doing pretty good on time. The protective factor framework chunks are going to be presented over the next slides with our working concepts aligned with them. So one of the fundamental concepts in early childhood development, administration of children and families. Thank you, Sarah Ball. You're amazing. You're so amazing. Are structural supports, which is basically ensuring like the access to tangible goods and services to address basic needs and alleviate stress. And so core elements of structural supports have already been defined by gravity, and there are correlating Z codes as well. There's not the correlating Z codes for the problem, but the structural support positive statements were all part of our goals terminology in those early domains. And so we present them here. Again, previously defined, like worked on with earlier domains and defined within goal terminology, but critical as like a family strength and protective factor within our work today. Next slide. The next, again, element within the protective factors framework, again, the synthesis of multiple different frameworks is the positive relationships that offer emotional information and cultural support for the person. So there's themes in here from the amazing presentation from National Indian Health Board and Dr. Jessica Sandwick-Ulrich a couple of weeks ago. So we have the general social connection, but what was really critical, and we heard that very clearly in Dr. Sandwick-Ulrich's paper, was breaking down social connection to different types that are supportive, connecting to culture, community, family, and friends. Very critical for adolescent health. Sarah DeSilva, family practice clinician, working with the AAP as that friend group from a developmental perspective. And then there's other really critical strengths that we know, having a trusted non-parental adult, which is why connecting youth to affinity groups or youth groups or clubs is really critical. School and environments. Oh yes, we do. We got that, Mark. It's coming. We have Connecting to Nature coming very, very soon. So these are all social connection concepts. We pulled out nature separately. We pulled out spirituality separately as well from Dr. Sandvik Ulrich's beautiful paper, and we have that on the Confluence as well. All right, next slide. And then on one page, we are kind of centering physical health and wellness concepts of eating well and caring about what you eat and exercising regularly. We all know that these are both things that we know are protective, things that we know are critical, but also things people are proud of. One of the things I think about all the time is and we're talking about this internally, is there's a question every single Bright Futures pre-visit questionnaire has, and kiddos 11 to 18 answer the question, what are you most proud of? And many of the kids I take care of say they're proud that they're strong. They're proud that they're good in school, right? And so that wanting to convey physical health and physical wellness as part of that is part of the general framework, but also it's a story that I hear consistently in my own practice on a daily basis. Again, so we have balanced nutrition concepts and physical activity and physical health concepts. Again, more to come very soon. Next slide. Oh, and sorry, the 1 hour of activity every day, that's a core American Academy of Pediatrics norm for wellness. It's a very tangible thing that can be measured, and we are exploring it because it's so directly linked to pediatric well-being and health. Next slide. So here's creativity. Very thankful for SMEs who made sure this was represented. So we had a lovely conversation on Tuesday about what it means to be creative and handy and be able to fix things. So we're exploring concepts in creativity, musicality, handiness, which is just, I'm a Vermonter, so that's the word we're using right now. Being artistic. And interestingly, SNOMED CT has lots of these things in deficit, again, problems of, but not the positive finding, right? It has purposelessness, but not a sense of feeling full of purpose, right? So we are exploring making these positive findings, again, to represent strengths in patient records and patient stories. Next slide. Here's the nature concept, right? So this again gets pulled directly from Dr. Sandvik Ulrich's own writings. And also we were talking today as a terminology group that for me, this is my primary connection to spirituality is, I was a farmer for 15 years. So this is very, very critical. Thank you, Lucy. We'll definitely explore that. So feeling connected to nature, very, very critical in the presentations we had a couple weeks ago. And we're presenting it here. And then mindfulness and spiritual connection. There already is a spiritual strength, SNOMED CT concept, but we're also exploring, really trying to pull in consistency from Dr. Sandvik Ulrich's presentation, feeling connected to your spirituality, and then also practicing mindfulness, which we know is critical across the frameworks, but also a very, very critical intervention for toxic stress. Most of these things you see as protective factors here, a huge chunk of them are so evidenced in addressing toxic stress physiology. They come in as goals and interventions in our toxic stress work, right? So there are consistencies here, things that we're proud of and things that keep us well and things that help us thrive are often the antidote to toxic stress physiology and toxic and traumatic experiences in childhood. So you'll see themes of these coming back again in our toxic stress work. Next slide. And so one of the things I can think about, Lucy, there is like when we presented the vital conditions framework, that the middle most crucial part of that in the ODPH equitable plan for long-term recovery and resilience was a concept called belonging and civic muscle. And voting is definitely involved in that insofar as a community level vital condition, but we certainly can I feel civically engaged. I feel like that's a strength of mine. So that makes sense to explore how that can be a strength as well. I've never not voted or gone to my town hall during a town meeting day, little New Englander. So we'll explore that, Lucy. Thank you.
I think civic muscle, I don't know that I've heard that term, but it's really vivid and quite poetic. And if
Yeah.
you'd rather say we need civic muscle in SNOMED, in a SNOMED code instead of voting, that's fine with me.
Yeah, so that's the beautiful concept. If you look at that, the Ripple.org Federal Plan for Equitable Long-Term Recovery and Resilience, that's a concept from the Ripple Foundation and the Vital Conditions Framework. I love it. Love it.
Thank you.
Mark?
I'm not sure where this fits, but what we're seeing so far seems to me to be more on the individual, the personal side of feeling efficacious, independent. I'm wondering if but we are in a political environment. This is sort of triggered by Lucy's thoughts. And I'm wondering if something like one's sense of dignity, that other people are treating one with dignity, that other people are creating the space, sort of finding some sort of abstraction from things like the United Nations Declaration of Human Rights, that this is how we are with each other.
So how we treat, yeah, we can.
And I skimmed ahead on the deck that was on the website, and I don't see as much on the sort of the political environment about how we're treated, and that seems like, anyway, it's also coming to me because we're talking about discrimination, which is about what others are doing against us rather than the efficacy that we ourselves have. Don't know if that was coherent enough, but
No,
it seems
I
like
hear you.
it's
I'm just gonna
focused on the
remind,
individual, and I'm wondering
yeah.
what's the corollary for the political context.
Yeah, so that again kind of relates to the community findings from the equitable plan for that beautiful thing. We did present community findings when we did the kickoff. I just want to note, just because we're an end-to-end review, if anybody wants something added, we really do need it in like an email. Otherwise, it's hard to like track change it. But those community findings in the Ripple Foundation paper totally center on that, on how we treat each other and what humane conditions look like for communities. It's going to make me really emotional. But I think there's a thread in there, Mark, which is relevant for the person level findings that we're doing right now. So if you want to send that in an email, we'll take it back to this Mies on Tuesday. It's somewhere here actually on the slide, right? So this whole slide centers on social emotional competence. It made me think about Lacey Wind, who was from the National Indian Health Board, her statement of being the water. And really, it also makes me think of some of our other subject matter experts in this domain who are guiding us to talking about the skills that one needs to thrive and not just survive. And so these are concepts of social emotional competence that largely already exist in SNOMED: self-efficacy, hopeful, empowered, confident, able to maintain self-esteem, psychological resilience, and competence. We do know that competence needs to be unpacked a bit because we're really talking about psychological competence and physical competence and some of our other skill sets. But this is partly relates to how we engage in community with our own individual skills. And I do think there's something about self-perception in here, Mark. There's room to explore, Mark, based on what the story I heard you just tell. Just thinking. All right, next slide. And the last concepts are concepts in really parenting and caregiver concepts in the framework. These really relate to the capacity for parents to help support practices and knowledge finding that help nurture thriving children. Robust in the literature of the Administration of Children and Families, the Center for the Study of Social Policy, Strengthening Families Framework, and all the practices of the American Academy of Pediatrics. Fundamental in what we do every day in caring for children is care for families and foster strengths within families. So demonstrating knowledge and statistically linked these to preventing trauma, abuse, and creating thriving children in the evidence, right? So we have demonstrating knowledge of parenting, demonstrating knowledge of child development, parental resilience, and not just childhood resilience, and promoting secure and stable attachment between children and their caregivers. And again, super critical within caring for families. in order to foster healthy parents and thriving children. Next.
Sarah,
Yeah.
I'm always struggling here because these concepts are so profound. What about knowledge of when to be a parent? I mean, if anything makes sense with respect to adolescent health care, contraceptive counseling, and all that, the notion of being able to decide when you should be a parent compared to what you were raised to believe or what people are pressuring you to do, is that in here somewhere? Does it belong in here somewhere?
Well, certainly within, the American Academy of Pediatrics has it kind of dialed down. Like for every specific age, there is a toolkit for what good parenting looks like for that developmental age, adjusted for kids with any kind of delay or need, right? So certainly from an AAP perspective, demonstrating knowledge of parenting looks different for a 2-day-old than compared to a 17-year-old, right? And so there's a lot to unpack in there, but I think you're correct to say that part of knowing how to parent is knowing when to parent. But that the specifics of that are not represented in the concept, even though they're absolutely represented in the pre-visit questionnaires and post-visit questionnaires of the American Academy of Pediatrics Bright Futures Toolkit. Every single one. I have a page I give to every parent saying, this is what to expect. This is how to support your kiddo. I don't know if that answered your question, but it's in there, I think.
That's great to hear. And as long as professionals understand that knowledge of parenting includes when to parent, not just how to parent.
Yeah.
Thank
And
you.
that's partly how development comes into, like, I think that's why it's not just note that knowledge of parenting is there, but knowledge of child development is not. So we're going to be adding that one. Okay, lovely. I hope I've accurately addressed questions while keeping us on target. I think we're doing good time-wise. I'm going to try to keep us going, and my apologies. I really just want to make sure we show you all everything. Next slide. There's so much content to discuss. And again, everything's going to be available on the master list. All right. Toxic stress physiology, end-to-end review. And I'm thinking, oh, our amazing friend. We have our friend, but we have a SME here for being a helper. And I will call him in if needed. Next slide. He'll definitely be needed. Next slide. No updates to instruments. These have been constant. We presented them, I think, about a month and a half ago now. Again, all available on the master list, on the master files at the end of the day tomorrow. Next slide. On diagnoses, next slide. There are some, we wanted to bring in, sorry. Oh, I think we can go back. Yeah, we wanted to bring in the categories again. We presented the categories when we presented the instruments because we wanted to ground you all in the top 10 categories that define, that are most evidence to define risk for toxic stress physiology. And these are the categories of experiences that the instruments assess. These are really critical when we think about diagnoses because we're going to have two different types of diagnoses in our work. One that assesses risk for toxic stress physiology and one really naming each of these different experiences. Again, so we have 3 different abuse concepts, neglect concepts, and then household challenges concepts. Next slide. So this is these are the diagnostic concepts that there's just one slight addition from last time that convey the risk of toxic stress physiologic response. Again, this is evidenced by the amazing algorithm that is evidence-based as part of the ACEs Aware methodology. Dr. Mackay Owen presented it a fair bit of time ago, and he's here with us today. So you can see a couple different code diagnostic concepts coming out of this, the 3 different risk levels in ICD and SNOMED CT. And because SNOMED CT usually asks us to ground whatever concept we have high, intermediate, and low in a method, the risk assessment algorithm will likely be part of that concept. Again, that's not changed from last time. Next slide. And then we're also going to pull in all of the specific diagnostic concepts that relate to these 10 experiences through two different lenses. There is this happened when I was a child and I'm an adult, and there is this is currently happening now and the child is in front of me. There are two different lenses we have to consider here today. Only are the adult look back concepts. We have a host of content to present to our subject matter experts on Tuesday to try to review the current childhood experiences concepts. But we have personal history of physical and sexual abuse. Again, that was that top level. Personal history of psychological abuse in childhood. Personal history of neglect in childhood. And again, the correlating SNOMED CT concepts. Next slide. And then this is a little tricky. The wording is something that we're definitely working through. There's a significant gap in representing household member concepts. And again, that's that whole bottom of the top 10 categories. Is not that it's happening in the household environment that the child's in. So we're having to explore, and again, the wording's tricky. When you, as a kid, had that experience of separation or divorce in the household, when you had the experience of having a household member incarcerated. We did explore this concept in our history of our incarceration status domain, so it's coming back. We're going to be developing concepts to represent substance use, I should say, in the household, and then household member intimate partner violence, and then mental illness. Again, all those core concepts of the household challenges. Yes, Lucy?
What is the difference between household and family member? Like what if,
Hi. Would
I'm
you
sorry,
like? No, can
go
I
ahead.
call you in, Dr. Owen? Are you with?
Yeah, I'm with you.
Yeah, so she asked why it's household and not family in the categories.
I think a lot of that may be, at least from my perspective, how it was framed in the original ACEs study and how the original ACEs study may have been replicated. And I think, from at least my standpoint, if we were talking about ACE screening, for example, that would really, a lot of that I think would be in the context of how either the child or the caregiver would interpret and answer that question. And I don't know that there's a real clear answer in the evidence that we could draw from to make that distinction.
So our use of the word household aligns with the methodology in the top 10 categories, is the simplest thing to say. Makai, is that fair?
Yep.
Okay.
Thank you.
Mark?
Not sure if this is relevant here, but in the census language, the household is the group of people living in the same place, and they may or may not be connected as family members, but they may be influencing each other.
And that's
Yes,
exactly why I thought of this, because there could be family members outside the household with experiences like this that affect everyone in the household.
this is absolutely, I want to highlight one of the things, thank you so much, that we're like, because we are required to explore this with our subject matter experts, because most ICD language uses the word family. So know that this household family crux is something that we will deeply explore over the course of the next weeks to make sure that we get it right. The terminology team, we were just literally having, when I was slightly distracted at the beginning, is because I was wrestling with concepts of family and household. So just know that you are echoing, an interesting nuance with an existing terminology itself. And this is, again, part of end-to-end review, and we'll figure it out with the SMEs as we go forward. Go team. Janice?
Yeah, I just wanted to touch on that. Yeah, family household could be family, but it's who lives in the house. Like I lived with 8 women in a house, right? And so we weren't related. But also sometimes there's, people bring in extended family members and they might consider them family, but they actually aren't. I mean, we went through a big thing with that with housing here within the Native American community to be sure that they could include these people in their household because they had a fine definition of family at the time. And so the term household is actually more inclusive than just family. Yeah.
Yeah, and we literally, like, amazing Asha Emanuel and I were just having that little conversation a couple seconds ago. Again, there's a lot of ICD family language. Household is new, and luckily our amazing SMEs in ICD, I know, Sue. I just didn't even have to. I didn't have to say anything, and one of our amazing ICD wizards came to bear. Sue Bowman, thank you so much. All right, do have a lot of content to get through, so I'm going to keep on trying to go. Next slide. All right, so now we have a host of interventions, and I think we're okay on time, and we'll be able to get to our racism content. Thank you all for bearing with us and sprinkling in necessary conversation that so far has highlighted themes that we've been thinking about, and thank you so much. So great minds think alike, and many hands make labor light. All right, interventions. A lot of content, 3 domains. Here we go. Next slide. All right. So, Makai, I'm going to just call you in for as much of this as possible. Again, this is so based in, the gorgeousness of the approach that you see is entirely built upon the bedrock of the ACEs aware methodology, of which Dr. Owen is representing. And so I just own as much as you wish of this, Makai. And if I get anything wrong, please let me know. But within our toxic stress interventions, we really are centering and grounding ourselves on the evidence of what is significant in considerations of preventing and addressing risk of toxic stress physiology. There's lovely cool toolkits at ACEs Aware that detail approaches for each of these different stress busters. And you can see again, already those themes that we had and our strengths are coming back here. Yes, maybe that's part of supportive relationships. Next slide. So there's a couple different things you're going to be seeing in these slides, because we're not just educating about the problem in these education concepts, or we're not just promoting steps towards addressing a certain program. We really are centering our language around those stress buster concepts, because that is what, it's a huge part of what we do in clinical practice every day, and the evidence and all of the implementation materials you need are right there with ACEs Aware. So you have the quality sleep, supportive relationships, balanced nutrition, physical activity, experiencing nature, mindfulness, and mental health care, education concepts. And then Dr. Owen consistently talks about how critical it is to educate the individual about how toxic stress physiology actually works. So these are core education concepts within our toxic stress domain. Next slide. We have a switch. I kind of did something that we've never done before, and I couldn't actually back it up. So when we were originally working as a subject matter experts, we had with subject matter experts, we created these creation of care plan concepts, but we actually represent care planning differently within Gravity, and I kind of lost that thread. We talk about care planning as it relates to goals. So more on that shortly, but this is partly where those promotion concepts came up. Right, again, critical to the work of pediatrics, family practice, prevention. Health promotion is pretty much half of what I do during my day in family practice, right? So again, you can see these core stress buster concepts and promoting each of them, promoting quality sleep, supportive relationships, balanced nutrition, physical activity, nature practices, mindfulness practices, and mental health. Right. And again, those promotion concepts will come back when we think about strengths, because we do that same thing, like promoting resilience, promoting self-efficacy, promoting creativity, right? So you're going to see that come back. And again, you can see the stress buster concepts weave through throughout. Next slide. Oh, okay. What is I'm trying to so there's some great, there's a whole amazing list of interventions on the master list you will see tomorrow, a whole set. We are highlighting only the new ones, right? There are some really common themes across domains, some common programs, and some things that are new. We already had we addressed it on the promotion introduction slide in 2022, based on the National Academies of Science and of Medicine. Bye, Josh, see you soon. We added a different type of intervention called adjustment, again, based on the National Academy model of intervening on social risk. And so there already is a gravity concept called adjustment of clinical plan to accommodate social risk. And so that's like changing the physical therapy location if your patient's transportation insecure and can't get to it, or changing the insulin regimen if your patient is food insecure, just to make sure that you're, meeting them. This is such a horrible thing, but there's things that we just do to try to keep people well, adjusting what we do in clinic in order to meet their needs. And the same thing happens, Dr. Nadine Burke-Harris has been very clear, and Mackay as well, that the same thing happens when you recognize the risk or the presence of toxic stress physiology. You adjust your plan, right? You choose different medications based on what you know about the way toxic stress physiology manifests in the body. So we have our second adjustment concept here, which is adjustment of clinical plan to address toxic stress physiology. And then we have 6 new programs, which you'll again see in the racism domain, at least some of them: trauma-informed network provider, affinity group, which is a group of belonging, and I refer, for instance, lots of my queer teens to the local, like Outright Vermont, which is the teen center for LGBTQIA kids in my hometown. And then there's mentoring programs, youth centers, after-school programs, language classes. Mackay, am I missing anything? Am I doing okay?
Doing great.
Okay, you've taught me well. If you you taught us well. Next slide. And I think so. Okay. Any other questions, Mackay? Do you have anything to say before we move on to racism for the final half hour? Do you want to add any pearls?
I think the only thing that I would really add is, for at least ACEs aware, when we talk about kind of those evidence-based strategies, like why those, they all have been shown to reduce stress hormones, reduce inflammation, have an impact on neuroplasticity. So kind of key mechanisms that would kind of mitigate toxic stress. And there's lots, I think we've had lots of conversations about other things that may mitigate toxic stress, may prevent toxic stress. And more research is ongoing and needed. But those are the ones that we feel like had a lot of strong evidence of kind of working on that physiology.
Thank you. It's amazing. Go team. And again, that household family thing is something we're deeply centering on. Again, literally, it was what Asha and I were talking, if she can attest, is literally what she and I were talking about like 2 minutes before the meeting started. So we'll come back more with that. And then thinking about those concepts you raised, Mark, and if you can submit an email, that's really great, so I can try to capture it. And then the civic muscle concepts. All right. Okay, on to our next domain. This is our end-to-end review for person-level racism concepts. We do want to note that even though we're naming this as person-level racism, part of the work we're doing with SMEs now, from our completeness perspective, is ensuring that we figure out ways to name structural racism in the experience of individuals, and ensuring that we name organizational accountability, even if it's a person-level experience. So person-level defining the concepts at base, but there's a lot of conversation on structural findings, structural accountability, and structural racism throughout the work we're doing with subject matter experts at this time. Next slide. All right, so next slide. There are the fundamental gold standard instruments to identify racism have remained unchanged. You can find them on the master files on the Confluence. They've been there. They've really been steady since our first meeting. So subject matter experts, they're just so best in class. Next slide. Next slide. We have those instruments were actually curated by Dr. Williams at Harvard, and this is the definition of racism that's been in existence for some time, since 1995. The definition of racism driven by Williams and Collins. Racism is viewed as incorporating ideologies of superiority, negative attitudes and beliefs toward racial and ethnic outgroups, and differential treatment of members of those groups by both individuals and societal institutions. This definition has grounded our approach to racism as inclusive of both racial and ethnic discrimination, and you see that throughout the terms and instruments over the next slides. Next slide. Next slide. So again, we are telling person-level stories of racism on a broad level. We're really trying to lean into concepts that talk about trust. And then we are trying to make sure that we tell stories of all the ways racism manifests in the experience of people, including internalized racism concepts. Next slide. There are some changes. This is very much a work in progress. I cannot understate the amazing care our subject matter experts are taking to make sure these terms are representing exactly what needs to be said. Lots of weighing of risk and benefit of naming, critical things, really leaning into storytelling. So in order to ground ourselves in what needs to be said, a lot of our time with subject matter experts is just listening to subject matter experts tell stories that drive the language they wish they could have had to name critical events, critical experiences. So this is it's like one slide, but there's a lot of thought going in here, and there might be changes over the course of the next weeks. But just want to let you all know that coming back to these concepts every week is what we're doing right now, really driven by the immense care and expertise and thoughtfulness for subject matter experts and the amazing people on our own team who are experts in their own right. Again, not myself. So we have some revisions. Our subject matter experts were very clear that they felt like target of racism was a better concept than victim of racism. And we are going to be exploring that precedent with SNOMED CT. As mentioned, we are exploring concepts in internalized racism, how it affects both healthcare outcomes via the service provider, and how it affects individual health. So we have two revisions here, really trying to lean into specifying what exactly we were trying to say. So the first concept, internalized racism of service provider affecting care outcomes, was revised because we wanted to be entirely clear that this is being on the receiving end of internalized racism. So it's not the person's own internalized racism, it's the internalized racism of the service setting or the service provider affecting the person. The second concept, we have two different things we're working on here, trying to name how internalized racism affects the self. And so we have the prior one that we presented a couple weeks ago, which is perceptions of self affected by internalized racism. Again, still nuancing these and thinking about these. And then we are trying to think about how to bind it to accountability and outcomes. And so we are nuancing a second concept, which is internalized racism of subject affecting care outcomes. Again, really trying to name what that is linked to an accountability, that's something we're trying to address. And just again, lots of storytelling, lots of listening, lots of making sure we're getting this right. And this is just something I imagine the subject matter experts coming back to repeatedly over the course of the next weeks. Then remain unchanged are the concepts in discrimination affecting trust and service provision, and then a specific concept of experience of racism affecting trust and service provision. Those have not changed. Mark?
Sorry, I'm not remembering what service provision means here, and I'm checking because that could cover quite a gamut of things from health services to police services to possibility of voting? Hence the question. Thank you.
So originally, we only had a healthcare team or care team. And then it was brought to mind that discrimination and racism can affect service. Like we use service provision in the broadest sense of all the places people receive care and receive services. Service provision is used in other settings really to be the common thread across social care and healthcare. And that's kind of how it's used here as well. We are definitely in the process of refining it, but that was what it was intended to meant, is wherever anybody is going to receive services, whether they be education, food bank, clinical practice, and we expanded it to service provider for that purpose.
So it's healthcare centered, broadly speaking.
It's not healthcare centered. In this one,
Aha.
it's bound to care outcomes, but service provider is fundamentally not just healthcare centered.
Would
It's-
it include police services?
I don't know if police are service providers in that sense. We'll get the definition going, but it's like service provision is a concept we've used again in the past to represent the consistency between healthcare and social care. I don't think we've used it for carceral systems.
Okay,
We'll
and
get
I
it.
only mentioned that as an example, not meant to just focus attention on just that one thing, but that's the reason for asking about the definition. Thank you.
Yeah, I think we'll definitely are going to get the definition. I'll have to pull the definitions back that we've had in the past, but service provision is the concept we use across our social care program classification as well, really talking about places you receive services, but not just healthcare. More to come.
So
Definition
this
coming.
is really provision of service by social and healthcare providers.
That is what
If
service
you unpack what service provision means, that's what you mean.
that is
So
what we
can
have
that
meant to
be,
say.
can that be stated? So Mark, just looking at this just as a
Health
random.
and human service provision.
Yes,
Yeah.
yeah.
Yeah,
Yeah, but even human services is not the same thing as social services.
social.
Right.
Yeah, it's
That
tricky
you
because
have to be
services,
eligible for, reimbursed
Yeah.
about, and all of that.
well, these are definitely in, thank you for highlighting that. I don't know if the definition alone is going to help, but we'll lean into it and try to fit. But again, it was created because originally we had just healthcare settings, and then we desired to expand it into other settings. And then we thought with our subject matter experts, they just came up with a why not service provider, since it's encompassing of all settings. So social services doesn't always fall under human services, Jonathan. It's tricky. We'll figure it out. We'll figure it out. Okay, and so I think thank you so much for these concepts. Again, maybe it's better to unpack them and keep two different terms to keep it clear, keep it healthcare and social care. But more to come on this. Know that these are generally the three themes that we're trying to represent, though. I don't think we have any subject matter experts except for our lovely friends on the call right now. Next slide. Next slide. I now am going to pass the mic over to my lovely colleague, Asha Emmanuel, who, due to the press of everything, I don't know if we've actually introduced the fact that she's back on the team. Lucky us. I don't think we ever did that, friend.
I don't
Or-
think so. I don't
No,
think
I know.
Yeah.
I'm just going to name that we have the luck of being joined again by the amazing expertise of the one and only Asha Emmanuel, who does a better job talking about these goals than I ever could. So I am passing the mic to her.
Thank you, Sarah. And it's so lovely to be back. So racism goal concepts. This is really where the rubber meets the road when it comes to designing anti-racist systems of care at multiple levels. So at the person level, we're working on terms like adaptively coping, which we're still refining, but it speaks to how individuals develop that resilient strategies amidst ongoing racism and discrimination. And an example of that, in my day job as a community health nurse specialist, I design culturally responsive perinatal education programming and content. And we always infuse within that the Hear Her campaign materials, as well as the Black Birthing Bill of Rights, just as adaptive coping mechanisms for community members. We also have Feeling Safe, which is already an existing SNOMED CT concept. But let's be real about that. In too many settings, especially for Black and Brown folks, psychological safety is a luxury instead of a baseline. So we wanted to call that out. The subject matter experts felt very strongly about calling out feeling safe as a goal. Moving to the care team level, we've identified respectful care and collaborative care as foundational goals. And these are not just buzzwords, y'all. They are actionable frameworks, both respectful care and the collaborative care framework. And they're vital to changing patient-provider dynamics to make them move from transactional to transformational. And then finally, at both the care team and organizational level, we're exploring accountability. And I mean real accountability, right? Not just the diversity training with no follow through. We're still shaping this concept, but it's central to institutional integrity, and it's aligned with Joint Commission regulation, which already has a safety event reporting mechanism. So we're excited about that. More to come on this, but these are the goal concepts that the SMEs really felt comfortable sharing at this time.
Thank you. Amazing,
You're very welcome.
Asha. And I
Thank-
want to note, I'm going to highlight again the care the subject matter experts have. Like, there's a lot of listening. There's a lot of silence in that hour we have with them every week, really just reflecting on, and there's a whole sea of things in front of them, and the care of what they feel ready to come to you all, even in it's like the previous slide were things that like conceptually we're working towards. There's going to be nuances there, but just want to represent the care of our subject matter experts in bringing these concepts to you this week. And Asha, thank you for representing. Amazing, Asha, giving us an education and respectful care every day. All right, next slide. And now we're on to our interventions. Again, any of our subject matter experts, again, our own Asha and Manuel to chime in. Next slide. Again, any prior domain program that was, super critical, like mental health concepts, restorative justice programs, they're already, let me think of it. That one, those are already on the master list, and we're only centering things here that are new. So here are the themes: affinity groups, mentoring programs. So you saw those in the toxic stress interventions, language classes, the same thing. I'm going to give a moment. I think I'm keeping my friend Asha on if she's wishing. We have the Honor Dissenter Communication and Resolution Program, which is the type of restorative justice programs. If we have time, maybe Asha can speak to the paper that is highlighted, and I believe that the reference is part of the master list and it will be placed in the conference very shortly. And then the last ones, and again, Asha, you can call yourself in, please help here too as well. But we really had a conversation about accountability when it came to interventions and wanting to make sure that we weren't just building interventions that about, adaptively coping or building thick skin, as one of our subject matter experts mentioned, that we really were building in the places people go to have justice and find justice and seek accountability. So you'll see on here, leaning into concepts to contacting and asking the state's attorney to come in the presence of experiencing racism. You can see us building in concepts for contacting the state's Office of Professional Licensure and Regulation if you feel like a clinician has discriminated against you. And so you want to bring it to the Board of Licensure and Regulation. We called in the ability to give reports directly to the Joint Commission if it's occurring with a Joint Commission setting. We called in the State Department of Health, which has a program, which have programs. And we called in patient advisory boards as ways to seek accountability, redress, support within clinical settings as well. There was a lot of conversation on programs that remain in the current moment in time, and wanting to make sure that we highlighted programs that existed and were not bound to fluctuating funding, but really rested in the core structures of states and systems to be able to move towards justice. And I don't think, Asha, I highlighted, but do you want to briefly talk about communication and resolution programs? I don't think I prepped you for that one.
Yeah, it's all good. No. So the communication and resolution programs, this it's actually fresh off the presses. It was just released a couple of weeks ago. One of the authors of this program is Ronald Wyatt, who is at IHI, Institute for Healthcare Improvement. And this is a restorative justice program for hospital settings, which is new, right? We haven't had a restorative justice program for healthcare settings before. So it's really innovative. It's a brand new program that is structured and systematic with a communication plan for when unintended harm occurs in a healthcare setting, and then a resolution plan for that. So it really is a way to address unintended harm that can happen with racism and discrimination in healthcare settings. So very excited about this and wanting to socialize it here with you all today.
Thank you, Asha.
Thank you, Sarah.
And we do all agree Ron Wyatt is wonderful. Dr. Wyatt's a national treasure.
Yeah.
I think next slide, I think that's actually,
That's it.
that's it. That's
Sarah,
it.
I wanted to point to boards of directors of
Yes.
nonprofit organizations with respect to accountability.
Yes, I mean, if I thank you for that. We encourage you to submit it via a formal email. Just to risk, but I want to note that if we're talking, that conversation we were just having regarding service provider is fundamentally trying to represent experiences that are not just bound within clinical settings. So absolutely, nonprofit boards are accountability mechanisms. 100%. Thank you. We're also exploring, there's a bunch of concepts that are still getting thought of, like, there's a bunch of concepts and interventions from programs that didn't make it over, that are still in process of being thought of by our subject matter experts. Any other thoughts? Thank you for letting us present a significant amount of critical content across our 3 domains. Thank you to our subject matter experts who are here and not here. We wouldn't be able to do this without you. Your wisdom, guidance, care, reflection is felt. Again, many of our SMEs, because of their area of expertise or because of where they hail from, coming to us in challenging times. Any other thoughts from anyone else before we go?
I did just think something about the last slide. Having been involved with youth and things like poetry slams and,
Yeah.
it's not always at a youth center. I was trying to think how you might capture some of that, spoken word and art opportunities. They're not always at a youth center, but I don't know. Anyway, a lot of them can be generated by them themselves, actually.
Yeah, one of the things I was thinking about is youth centers are not as inclusive as youth programming. Right. There's lots of, specific programming that happens not within centers, right? It's more, but yeah, thank you for that.
Like youth-led programming, right? It
Yeah.
might be an extra because youth centers generally are adults, but youth themselves lead programming.
Yeah.
So,
like our, our GLAD programs in high schools are all youth led. Like most of our
Right.
affinity groups in high schools are youth led, 100%. Yeah. Any other thoughts? Thank you. Okay, next slide. End-to-end review. Next slide. Next slide. There is going to be a lot of content that on the master lists when the amazing team puts them up tomorrow at the end of the day. And we have only put a fraction of what's on there on the slides today because we, for the sake of time, committed to focusing on things that we, largely that were new and we are exploring with you all. We will take your thoughts as much as we can with us to the subject matter expert, but because it is end-to-end review, if you could send emails, it's really helpful to gravityproject@8till7.org. So download those master lists, reflect on them. Our job over the course of the next weeks until May 29th is to refine them, to think about them, to add things that are missing, fix things that are incorrect, and to remove things that we feel like are unnecessary. And not even just unnecessary, like when we did an incarceration feels that if we're moving things that we feel like are greater a risk of harm than benefit when we think about things from our data principles perspective. We thank you all for your engagement and involvement. We will see you in 2 weeks. Send us your emails, download those master lists, and we will see you soon. And we wish you a peaceful and well Thursday evening. And thank you so much for coming. And thanks so much for our subject matter experts, Asha and Sarah. Monique, thank you. And Susan, very grateful for the amazing women of terminology I work with every day. My friends.
Thank you.
Thank you.
Sarah
Thank you.
Sarah.
and Aisha.
Thanks, Sarah.